purpose of this presentation is to summarize 10 key points from the background materials for Module 12, which focuses on global health policy in humanitarian and emergency settings. I know that many of you don't have a lot of experience in this area. We're only doing one module. This actually is worthy of an entire course. So I just want to focus on what I hope you'll be taking away from the readings. As I said in the announcement, I've tried to streamline the readings. There are 2 articles and 3 videos. The first article is actually a report called Hard to Reach, Providing Healthcare in Armed Conflict. This is the most substantive article. It's a good overview. It focuses on armed conflict, but many of the ideas and really the principles they're setting out are also applicable to natural disasters, and I'll talk a little bit about that during the rest of this presentation. Where Doctors Are Criminals is a relatively short New York Times article that looks at 4 case studies of doctors that have put their life on the line in armed conflict situations. The videos are 3. The first is Beyond the Data, Shifts in Global Health Security. This focuses a lot on the preparation of health systems for pandemics or sudden outbreaks of communicable diseases. Those of you doing case studies on Ebola will be particularly interested in this video. The second is Refugees and Internally Displaced Persons from Siri Tellier at the University of Copenhagen. She talks a lot about what we're seeing in terms of the evolution of health needs in refugees and internally displaced persons. And the third is Médecins Sans Frontières, or Doctors Without Borders. It's a promotional video, and I really want you to look at this just so you can see the kinds of settings that humanitarian global health organizations work in. Médecins Sans Frontières is not without criticism, but it's one of the purest humanitarian health organizations with the widest reach. So, key points on global health policy in humanitarian and emergency settings. The first is that armed conflict is a global health issue. It's an important social determinant in health, and it poses significant challenges to health systems in affected countries. So this is a global health issue, as are natural disasters when they occur. The second key point is that conflict-affected states have among the worst health indicators and the weakest health systems in the world. This is brought out in a couple of videos as well. The CDC video talks about how there's a desperate need to strengthen these health systems. Siri Tellier talks about the health systems that IDPs and refugees are forced to rely on. But in all the materials, you can see that often conflict comes to countries with the weakest health systems. This isn't always the case with natural disasters, but often when you see a natural disaster occur in a developing or low-income country, it will come on top of a weak health system. And the kind of health system, the indicators that tell you that conflict-affected states have the worst health systems or the weakest health systems are a lack of infrastructure, a shortage of personnel, a lack of data, a lack of money, high levels of private sector involvement. And you might say, well, why is that a bad thing? Well, it's mainly because often, particularly in conflict-affected states, this private sector provision of health care is not under the control of the government or an international organization. There's no quality control, and it's often too expensive to be accessible. The article talks about Syria in this regard. For lack of infrastructure, it talks about Yemen, in which during the last few years of the conflict, a full 50% of the health infrastructure has been damaged or destroyed. And it also provides examples of shortage of personnel in a number of countries. The article from the International Peace Institute also talks about challenges to health system delivery in armed conflict situations. And again, this would apply, some of these would also apply to natural disasters. But in security, where they talk about the Central African Republic, where people have to travel way out of their way to get to health centers because of the dangerous routes that the shorter routes are too dangerous, therefore at great detriment to their health. Legal and administrative barriers. This includes the high-income countries that declare other countries as terrorists or put in counter-terrorism laws that block health support to some countries. Also, the example of Gaza was used, where Palestinians in Gaza need all sorts of administrative permissions to cross over into Israel, where they could get better health care when they really have a problem. Militarization. This would include the use of health centers to store guns, equipment, or other military supplies. It would also include the taking over of health centers in order to serve the needs of soldiers or armed combatants. And sometimes just prioritizing those combatants over others, and sometimes taking over the entire health sector or the health center. And I've certainly experienced this in some of the countries I've worked. Politicization, and I experienced this in Burundi, where the government only wanted health care offered to the side of the conflict that they felt was friendly to them. So you wouldn't be allowed to offer health care to people or communities or groups considered to be part of the opposition or the rebels. Poor governance, movements of people. This was very much talked about in the Siri Tellier video on internally displaced persons and refugees, making it difficult to offer health care. And increased vulnerabilities. And the article talks specifically about women, about children, and about disabled people in this area. International assistance also plays a role in the difficult delivery of health care in armed conflict and natural disaster situations. International assistance is often short-term, it's donor-driven. We often say that who is going to be still giving money when the CNN cameras are turned off? In other words, there's lots of donors when a conflict is in the news or a natural disaster has just happened, but there's much less to really take care of the issues, the problems, and the needs that are longer term. Donors also tend to fund what they think is important rather than what local people might feel is important. International assistance is often disrespectful of capacity, of local capacity and local organizations. It's often politicized. We often see this with the U.S. Who does the U.S. government provide assistance to or not? The next point is about the continuum of care. We hear about this in a variety of different ways, and I've worked extensively on this in my career with the UN and afterwards. But the continuum of care refers to the connection between humanitarian relief operations and longer-term development efforts. So humanitarian health and development actors often work on parallel tracks rather than together. And again, this often happens in natural disasters where, for instance, when I worked on the cyclone in Myanmar, there were many donors willing to hand out food to fishing communities. There were many fewer donors that were willing to actually give these communities or groups or families money to buy new boats or to get restarted with their livelihoods. So often there's a whole lot of money and a whole lot of attention to life-saving efforts, but not as much to what comes afterwards. In the UN, we referred to this as a humanitarian development nexus, which you read about in the article, but also when I was at UNDP and leading recovery efforts, we referred to this as the early recovery period, which often got no funding at all. And the article cites, the report cites Nigeria, just to give an example of how this goes wrong. The next point is that despite a growing consensus on the need to strengthen health systems as a whole, instead of focusing on single-issue health interventions, non-communicable diseases, mental health, and sexual and reproductive health are chronically underfunded. The video by Siri Tellier talks about this at some length. and says that, recently we've seen many migrants and movements of people from middle-income countries, for instance, Syria, and these migrants tend to be older, and they also tend to suffer from a variety of non-communicable diseases, whether it's heart disease or diabetes or kidney problems, both because of the kinds of countries they come to, but also because of their age. And often in humanitarian or refugee operations, non-communicable diseases are considered a luxury, and everyone just wants to focus on the life-saving efforts. And not that this is wrong, but again, unless you move to the next step, a lot of people are not going to get the kind of care that they need. The next point is that global health policies and interventions in humanitarian and emergency settings need to be more context specific. This requires a better understanding of existing structures and services and genuine commitment to localization. So, for instance, sometimes international organizations offer services to women in settings or in ways that the culture that these women are embedded in makes it impossible for them to access those services. For instance, if you have male doctors that are offering services to women in Afghanistan or in some other settings. And also this genuine commitment to localization. We learned something about localization in the last module, but the point here is that there's often a willingness to use local organizations as implementers under the guise that local organizations understand the context more, they're already on the ground, they understand the dangers more, but there's much less willingness to involve these local organizations in the design and decisions about how aid is provided and what interventions are funded. The eighth point is that there is an imbalance between financial accountability and performance accountability. And the report, the International Peace Institute report, talks about this at some length. But financial accountability has to do with accountability to donors, because you want more money. Performance accountability has to do with accountability to the people you are serving, which also gets second priority to the financial accountability. The ninth point is that in conflict situations, the state, which should be responsible for the health of its citizens, is often one of the principal violators of international law. That's why when you hear in the Médecins Sans Frontières video, when they talk about not taking any money from governments because they want to be independent, and it's also the reason why impartiality, neutrality, and independence are key humanitarian principles, because often in development efforts where the state or the national or local governments would be your main partner, this is not viable in humanitarian situations because these entities, state entities, are in fact the problem. And the 10th point is that the rise of non-state actors as both drivers of conflict and providers of aid have complicated global health interventions. We have a very recent example in Mexico where the drug cartels are offering medical kits and survival kits and food and all sorts of aid to local communities. And the government, while of course it welcomes aid provided to communities, is trying to point out that it's not these groups that should be providing such aid. So on the one hand, the drug cartels are driving conflict in Mexico, and then suddenly they become providers of aid. So these are the 10 key points that I wanted you to get out of the 2 articles and the 3 videos. And this is a complicated area. As I said, it's a course in and of itself that maybe we can one day offer, but I hope this gave you an idea of the special situations and contexts in which global health policy and practice needs to take place in situations of crisis.